week. This is just kind of a national event, hence that's for a week, hence the name, that just kind of showcases various forms of health IT. It's done both at the national and the state and even the local level. There's lots of different activities that go on for the actual throughout the country. And so this week we've been doing a series of webinars highlighting the different services that we have that kind of fall under the realm of health IT. We started Monday with just an overview of services. Each day we've had other highlights of other services. Yesterday we had a really great webinar on privacy and security, especially as it relates to the EHR Incentive Program. And I really encourage you to join tomorrow as well, where we'll have some national speakers talking about the future of health IT, and then we touch on the future of the EHR Incentive Program as well. But in keeping with the theme and in keeping with kind of doing something a little bit different to kind of highlight and showcase, we thought it would be really interesting to kind of take a step back and look at how far we've actually come. Personally, I've been with the program since its inception back in 2009. Actually worked with Medicaid agencies prior to that, so kind of saw it coming. So for those of you who've been around, some of this will definitely look familiar. For those of you who are new to the program, it might just kind of give you a little historical context. So the EHR Incentive Program actually was funded through HITECH. And as part of HITECH, there was an act, the American Recovery and Reinvestment Act, that kind of gave the money to the states to actually start implementing the EHR Incentive Program. It was definitely part of a bigger vision at the national level to start really getting providers and states to embrace health information technology. There were a lot of money given to states at the state level to actually implement infrastructure, health information exchanges to allow providers to share patient information. And of course, having an electronic health record is kind of a foundational component of that. So back in 2009, all of this began. There was an authorization of roughly $36 billion for these incentive payments. And if you'll remember, you could either go the Medicare side of the house for up to $44,000 if you completed all phases of the program, or on the Medicaid side of the house, which we definitely focus on, for up to $63,750 if you completed all 6 years of the program. 2016, I think, was the last year to attest to Medicare. That program actually phased out and is now being replaced by the MACRA-MIPS program. But the Medicaid EHR Incentive Program is going strong and is slated to continue through program year 2021 or calendar year 2021. So when HITECH was actually released or implemented, depending on your point of view, it really kind of changed the focus of things. Up until that point, EHRs were kind of like this new thing. Only the bigger practices had them, the larger organizations had them. But the vendors saw this opportunity, as they should have, and really kind of changed how they even marketed and promoted their individual systems. Because, of course, to participate in the EHR Incentive Program, you have to have an EHR system. So it really changed the focus from increased efficiency and patient satisfaction to really saying, hey, if you get this system, you can get these incentive payments. Well, it really did the trick as well. Early days, and even now, providers are still kind of hesitant with some of the tools and techniques that are within an EHR. Probably a lot of focus is on the clinical decision support tools. We hear a lot of negativity about templates. We also hear a lot of positivity about templates within an EHR. They were real concerned that having all of this kind of functionality would change how they practice medicine and could even be potentially life-threatening to patients. Many physicians even wondered why we needed health IT. You know, part of the whole process and part of, I think, is the stumbling blocks throughout this has been helping providers, helping patients, helping staff, helping all of us understand the full potential of health IT and what that overall vision is. I think also in the early days, from a national perspective, they thought things were going to happen a lot quicker than they did. But with most things, it is a process. And here we are 7 years later, 8 years later, we're really beginning to see all of this kind of making a shift in the change of the way people think about health IT. So bottom line, you had the carrot and stick combination. Within Medicaid, there's only the incentive payments, but if you were also a Medicare provider and not participating in the program and not achieving the meaningful use measures, then you could be hit with a penalty. So you had carrots and stick, you had the carrot and the stick combination. So again, if you were with us in the early days, you probably saw this slide quite a bit. This was a national type of slide, and this was kind of that national message that we really tried to help providers understand. And when I talk about providers, I really mean it from a very broad base of providers, not just the actual provider of service, but support staff, ancillary staff, stakeholders, local, the local community, the state community. So providers is definitely used in a very broad sense here. So for improved communication, having the right information at the right time for the right patient, that would be huge. Not having to have patients, carry paper medical records from here to there, that would be huge. Better involvement. As we look ahead to stage 3, you're really getting to see more and more of that better involvement of that patient in their health care. I hear a lot of times from providers that non-compliant, they don't understand, they don't want to do what they need to do to be healthier patients. So again, Health IT can provide some framework for better involvement of that patient within their own healthcare choices and healthcare systems. Increased quality of safety of care and reduction in errors. Medication errors are huge. I personally have spent more time with family members in the hospital this year than I have in my entire life. And it's really interesting when you see the inner workings of a hospital and how much has to go on for that individual patient care. I could see where medication errors occur. I can see when patients leave the hospital or leave the doctor's office, they don't have a good understanding of why they're taking the medicine and the potential side effects and the potential counter when they counter each other out in life-threatening situations. And then, of course, we always have to look at promotion of cost containment. If the thought is if you have the right information, if you know where a patient's been, you know what services they've received, you know what their treatment plans have been in the past, then you can tailor your own care plan. You can tailor your own choice of tests, your own choice of medications to kind of build upon that and reduce a lot of redundancies. These things were put out back in 2009 when high-tech first began, and they still apply today. I think it's just taken everybody a little bit longer to really understand that these are some really basic kind of things that can happen when you have a good EHR system and you have a good health IT system overall. Remember this chart? Oh, this is a complicated chart. Back when the program began, we really participated for Medicaid. Everybody just start with AIU. Just have to have a system. How easy is that? Have a system, get $21,250. And then it got really complicated after that. Depending on when you started in the program, depending on what you attested to, would really dictate where you were for the next program year. So this chart, just kind of threw it back up there because we spent a lot of time on this chart in the early days. Stage 1. So after everybody attested to AIU within the Medicaid EHR Incentive Program, you jump right into stage 1. Now, if you were a Medicare provider, you had to jump right into stage 1. So stage 1, you had the core measures. You had 13 core measures. Everybody had to meet these measures. There were certain thresholds, certain yes-no measures, but everybody had to meet all of these. And a lot of them were redundant. If you maintain an active medication list, more than likely you're also going to have an active medication allergy list. So as the program kind of evolved, you see some of those redundancies reduced. I think you can say that. But don't forget about our menu set. So not only did you have to attest to the core measures, you also had to attest to the menu set. But you got to pick 5 out of 10, but you did have to have at least one public health measure. So, early on, it was complicated, but trust me, it got a lot more complicated. And then we moved on to stage 2. In the early days, all providers attested to at least 2 years of stage 1, and then they could move on to stage 2 measures. So we had everybody on the path to do AIU, to do stage 1, to do stage 2. You went up to 17 core measures. A lot of the thresholds really increased. Like for demographics, it went from 50% of your patients up to 80% of your patients had to have their demographics recorded. It was a little more emphasis on patient engagement, where in the past only maybe you had to have a functionality or maybe only one patient had to do something. Then providers really started getting measured on patients' actions. 5% of the patients had to send a secure message. 10% of the inpatients had to actually access their health information. Because of concern of actually measuring a provider on a patient action and the patient's action within their own portal or patient portal. I'll leave it at that, patient portal. You know, CMS kind of backed off on that, and there was a lot of concern. There was a lot of provider concern. I remember those days, and you may remember those days too. So then, in an effort to fix that, CMS came up with the 2014 Certification Flexibility Rule. So not only was it kind of complicated to begin with, then, because in order to move to stage 2 and in order to move to some of the new meaningful use measures, you had to have upgraded systems. Well, guess what? The vendor community could not comply with the new certification requirements in the time frames that CMS was looking at. So CMS kind of backed off and said, okay, if you have this system, you can do this. If you have this system, you can do this. If you have a combo system, you can do this. And it was really a nightmare. For about a year, it was really a nightmare helping providers understand not only what they could do, but what they should do. But then we came up with modified stage 2. Remember, a lot of providers were upset about being measured on patient action. Well, in the midst of the certification flexibility rule, CMS came up with what they called modified stage 2 to kind of address some of those providers' concerns. Now, personally, I thought it was a really good move. Modified stage 2 really kind of aligned everything. Up until this point, you know, depending on how many years you were tested, depending on what type of system you had, dictated what you could and should attest to. But modified stage 2 just kind of put everybody on a level playing field, much like they probably should have done early in the program. There was no longer stage 1 or stage 2. Everybody attested to what they called modified stage 2. So it reduced the number of objectives to 10. There is still one public health measure, but everybody has to meet it. It reduced a lot of those duplicative measures. Remember the medication list, medication allergy list, demographics, a lot of those were removed because providers indicated that, hey, this is very redundant in what we're already doing. And if we're doing this measure, then we're automatically doing this measure. So part of the streamlining was kind of just cleaning up the list. It did allow everybody to have a 90-day reporting period. One thing I failed to mention, depending upon, again, where you were in the program, you either tested meaningful use for 90 days or you tested for a year. Again, who knows? Everybody had to kind of be on a different kind of path. So modified stage 2 put everybody on the same path. And the biggest thing it did was it really looked at those patient engagement measures and backed off on it some. But also as part of modified stage 2, don't forget that we had our alternate measures or alternate exclusions. So in recognition, as if you were supposed to only be attesting to this level of stage 1 meaningful use measures, and all of a sudden we moved you up to this level of meaningful use measures, depending on your program year, depending on how many years you had participated, you could get an alternate exclusion, which basically said, hey, you don't have to attest to that. So again, a lot of program complexity, a lot of program confusion. And we hear that a lot from our providers that, you know, just tell me what you want me to do and I can comply with it. So whereas modified stage 2 does do a lot of that, there were still some problems and some bumps in the road early on. Most of them, though, were to the provider's benefit. Remember those alternate exclusions? We used to call them get out of jail free cards. So if you ever attended one of our workshops and we were talking about modified stage 2, we often passed around the get out of jail free card. And now, in 2017, program year 2017, so in 2016, we still had some alternate exclusions that providers can take. There was still some flexibility depending on how many years you were tested to meaningful use. And then at the end of 2016, they came out with what they call, or I'm calling modified stage 2. So again, everyone still has the 10 measures that they have to attest to. Everyone still has to attest to the CQMs. But what they did with modified stage 2 is because providers were still having a hard time meeting some of the meaningful use measures, they went and allowed everyone to have a 90-day reporting period for both their meaningful use measures and their CQMs. Now, we hadn't even talked about clinical quality measures. Back in the day, you just picked some clinical quality measures. You didn't have to pass them. You just had to be able to report them. Then, as part of the program changes, you had to report 9 out of them, and you had to report across 3 quality domains. Now, with modified stage 2, Now providers only have to report CQMs for 90 days. They still do not have a threshold that they have to meet, but they only have to report 6 of them. And they no longer have to cross those quality domains. And again, some of these changes were in response to provider concerns that, hey, my system can only do these type things. Or I don't really, if I'm not even having to pass the CQMs, why do I have to report so many of them? With the advent of MACRA and MIPS, they only have to report a limited number of CQMs. So they really tried to align all of that together so that there would be kind of a seamless quality reporting program. So quickly, stage 1, stage 2, modified flexibility rule, modified stage 2, and now we're operating under what I call modified stage 2. But I hope that you will see that there has been a recognition at each of these changes in response to concerns that have been brought up by those people who are actually doing it, those providers who are actually trying to provide services and still qualify and meet these meaningful use measures. Looking ahead, CMS also, as part of modified stage 2, is going to allow providers to all consistently across the board only use a 90-day reporting period. And then they'll also have the flexibility to either continue to attest to the modified stage 2 measures, or they can move on to stage 3. Before modified stage 2, every provider had to immediately progress to the stage 3 measures, and the majority of providers would be testing to a full year. So again, flexibility, some responsiveness, and again, the intent here from CMS is in the national perspective is to keep people within the program. I'm not sure what that BP is. Okay. These are the modified stage 2 requirements. We continually have webinars on the requirements, going through them specifically, additional tips, things along those lines. With modified stage 2, it's been around long enough to know that I think providers have a good foundational understanding of what is required to attest to for program year 2017 to these modified stage 2 measures. With the change on the clinical quality reporting, it'll make it easier because everyone's only going to be reporting for a 90-day period on that as well. We know that providers still have trouble meeting some of these measures. Health information exchange, that's getting that patient information from point A to point B. We still hear a lot of providers having issues with they could do it, but whoever they're trying to refer the patient to or transition the patient to is not either willing to accept an electronic transmission or they have no mechanism. So we're continually to look for ideas and opportunities and educate providers in that realm, and you'll see more and more of that. Secure electronic messaging, that's where a patient has to send you a message. At least 5% of your patients have to send you a message for program year 2017. Well, that can be, that depending on your patient population and depending on the pure volume of your patients, that can be a real issue. So we really encourage providers for secure messaging just to make that whole web portal, their patient portal, an integral part of every visit, that it's continually being educated upon, it's continually being shown, the benefits are being shown, and having the flexibility of a 90-day period can kind of help you start tracking it early and measuring it all along the way. Now, I will say for those providers who are getting ready to attest for program year 2017, you're in your last possible 90-day period to be able to meet the meaningful use measures. So if you've not already run your meaningful use reports, tracked your progress, find out kind of where you are on these measures, this is the time to do it. I was trying to think, there was another one. Oh, the patient electronic access, that goes into that patient portal. Not only do you have to send at least more than 50% of your patients have to have access to it. I can't remember off the top of my head what the actual percentage is of those who actually access the information. So again, if you're promoting the patient portal, if your staff's promoting it, if your provider, if your physician is promoting it, at every visit, it's just part of an integral part of their care. And not only can you meet the patient electronic access measure, but you can also do your secure electronic messaging measure as well. Run early, run often. Do that with your meaningful use. Again, if you've not run that report, I would go ahead and do it. It also, with having to only report for a 90-day period for program year 2017, you're going to have the flexibility to find that 90-day period in which you're meeting the measures. The other thing for program year 2017, we are still working on our system changes. It looks like it's going to be the December time frame before the system is open to be able to accept program year 2017 applications. We will definitely have our grace period like we have in the past, still kind of working out the details on that. So go ahead, get your stuff together, kind of know whether or not you're going to meet the measures, so as soon as that system is open, you can attest if you've completed your 90-day period. So let's talk a little bit about the impact. You know, there's been a lot of confusion, granted. There's been a lot of back and forth, granted, but it really has begun to see an impact. So these are some national milestones in terms of the program. Some of these numbers are both Medicare and Medicaid. So as of July 2017, there's been 533,000 payments made through the EHR incentive programs. That is representing 201,000 unique participating providers. So yeah, are these providers only doing it because they get an incentive payment? Maybe, but hopefully by having an EHR and hopefully being able to make it more part of your everyday workflow, you'll also be able to see some of the benefits of it and some of the ways that you can kind of use it just outside of patient management. There's a lot of cool, really health IT things that are going on that having that EHR is kind of a foundational component of. $12 billion have been paid through the Medicaid incentive program alone. There's 91,757 providers have completed MU. One of the concerns early on in the program, and it was a valid concern, and it is, when I say providers just attested for the first year because it was the highest amount of money, $21,250, and never had any intention of coming back for MU. For some providers, it just wasn't feasible to actually achieve meaningful use. We saw that a lot with our specialists, especially our really subspecialists. Dentists sometimes have a hard time meeting meaningful use requirements. So there was still a big push to get everybody at least into the system with that AIU payment. And then we're really working with those providers to continue to stay within the program and attest for meaningful use. 2016 was the last year that someone could begin participation in the program. We're seeing a pretty high number of year one applications for 2016. We're still working through those applications, but now our focus is really going to be helping those providers who have at least begun participation in the program continue participation, meeting the meaningful use requirements. You can see the return rate, pretty significant. Nationwide, we've had 2,180 providers completed 6 years of the program. So the end goal is to have as many providers complete all 6 years of the program as feasible. We know that that's not going to be applicable to everyone. People move, systems change, circumstances change. But again, our focus is to keep these providers in the system and helping them to meet those meaningful use measures year to year. From a Florida perspective, as of last week, we had made 14,736 payments just in Florida. That represents 8,755 unique providers. So we do have a pretty significant return rate as well. Now that the year one or those people who are just started the program kind of settle down, we'll really be able to measure our return rate much better because we'll see those providers who continue to participate in year 2, 3, and 4, and I have some numbers on that. This just kind of gives you this chart, just kind of gives you the number of apps by program year. 2013 was a banner year for us, as you can see. The 871 for program year 2016, that's pretty significant in that we're still actively working program year 2016 applications. I think we have over 2,000 program applications that our processors are doing a fantastic job of getting those processed, following up with the providers, whatever. So we'll see that number definitely increase, but I think 2013 is still going to be our highest year. In terms of program year, as you can see by this one, year one, some of my labels went off. Year one, the first line, was all year one applications. And then as you can see, year two, we had about even of year one and year two, those providers that actually came back for meaningful use. And then you can just kind of follow it on down. I don't know what happened to my lower levels, but it's 2011 through 2016. And of course, 2016, those applications are still being worked. So it's just interesting to kind of see the number of providers that are coming back. I think we actually have 10 or 12 program year 6 or 6 years of the program so far in 2016. So in terms of overall electronic sharing of information, now you don't always have to have an electronic medical record to be able to avail yourself of some of the services, but it really does help. And it really does make sense to kind of start with having something within your own office that actually allows you to capture an electronic format and share patient information. So this is from the CDC, and this is actually from 2015. They indicated that 38.2% of physicians had electronically sent patient health information to other providers, and just a little bit more had actually received it. So there is some exchange of that information. 31% had actually integrated that from other providers. Typically what we see is that a provider might get something electronically, but actually assimilating that into their own medical record is not nearly as widespread. And then 34% of physicians had electronically searched for patient health information from other providers. So again, 2015, these numbers have probably increased some, but quite honestly, probably not enough, and definitely not where we want to be in the future. Here's just some EHR adoption stats. It's really hard to get good numbers on who has a system. So these were some stats that we found, I think actually came from a survey done. In March 2017, 67% of all providers reported using an EHR. Now, early in the program, back in the early high-tech days, one of the first things states were required to do was what they call an environmental scan. So we had to go out and find out exactly who already had systems, who already was using electronic health record. The problem is the definition varies. Some, especially back in 2009, they considered their practice management system an EHR. They might have an EHR, but it really wasn't fully functioning. It was just maybe a way to capture some electronic notes, maybe some electronic lab values. A lot of times providers would report, oh yeah, I have an EHR, when all they did was get lab values electronically. So I think the definition has gotten better, and definitely the utilization has gotten better. I think it's real interesting. Physician specialties with the highest adoption rates are internal medicine and pediatrics. We hear a lot from pediatrics, though, that they have the hardest time getting patients, their parents, to use the patient portal. I would think pediatric patients or pediatric parents would definitely be patient portal users, but we hear that a lot from the pediatric practices. Since 2008, office-based physician adoption of the EHR has nearly doubled from 42% to 87%. So, stats are just kind of all over the board depending on who you ask and what questions you ask. The states with the highest adoption rates are Wyoming, South Dakota, Utah, Iowa, and North Dakota. Of course, the first thing I think about is they probably have a less dense provider population, but that's okay too. Providers are actually beginning to adopt these systems, use these systems, and when I talk about this, I do want to let people know, we know there's still issues. We know there's still problems. Every week we get lots of different articles that still talk about some of the issues that providers see. There's a big concern that you lose a lot of your patient one-on-one. You lose a lot of that patient interaction. A lot of providers feel like they're just glorified typists when they talk. They're sitting there and trying to click around on a keyboard versus really, listening to a patient. Some providers use scribes, which actually can increase the cost of adoption of electronic health record, but it allows them to still be one-on-one with the patient. So we still have a long way to go. We've come a long way, but we understand that we still have a long way to go to really make this just part of what people do, much like your debit card or anything else that your Amazon shopping. But we're getting there. Here's just some EHR adoption rates. As you can see, from the 40% to the 67%, it's a slow incremental increase. We also hear from providers and the communities that, hey, yeah, I went out, I invested, and I finally just scrapped it. It just wasn't working for me. We're also beginning to hear about rip and replace horror stories. I bought the system, I implemented it, spent a lot of money, and it just didn't work, so I had to go to something different. I just say all of that to let you know that, we know it's not all Pollyanna. There are still problems and there's still issues, and as much as we can from our level, we're trying to help providers address those. So what's the future look like for EHRs? Well, I think in terms of the EHR incentive program, when we move to stage 3, there is going to be so much more focus on patient engagement and exchange of information. So as we've kind of come through this continuum, as we've, began in 2009, looking ahead to 2018 and all the way through 2021, this emphasis is not going to change. There's going to be more and more requirements that patients be engaged in their health care. Providers are going to be measured on patient engagement within their health care and that electronic exchange of patient information. In stage 3, the numbers of objectives actually decrease. It's a little bit change of how they're going to measure things, and I'll show you that in just a minute. But you're only going to have 8 overall objectives, just as you currently do with modified stage 2. You have different measures within those objectives. Whoops. Oh, it's doing so good advancing my slides. I'm so proud of myself. For example, you have to satisfy both measures on electronic access to patient information, and the number actually does increase. It goes up to 80%. So this is that patient portal, making sure that patients have all of the information necessary to access their patient portal. And then the second part of that is using, for more than 35% of your unique patients, that you're using the information from the electronic medical record, electronic health record, to actually identify that information. The reason these two are going together is not only do you have to use your EHR to identify the educational information, you have to provide electronic access to that. It goes back to your patient portal. So as you're working with your patients, if you're just now still trying to get your patient portal implemented or really kind of functional, just make it part of every day. Make patients have to go to that for information. I know it's really easy to kind of pick up the phone and call and ask a question, get an appointment, get a refill. But if you start kind of steering patients towards using that patient portal, it's going to work for some patients, not all patients. But that use of that patient portal is going to help you meet the meaningful use measures for stage 3. Coordination of care through patient engagement. You have to attest to all of these, but you only have to meet the threshold for 2 of them. So the first one, for more than 10% of your unique patients, they have to engage with the electronic health record. So is that through your patient portal? Is that through another means? It's going to be through your patient portal. So more than 10% of your patients actually have to go out there and do something with their patient portal. So one place you're being measured on accessing educational information. One, you're just accessing the patient portal as a whole. The second measure on here is that secure messaging, more than 25%. And then the third is incorporating non-clinical information or patient-generated data for more than 5% of your unique patients. So again, how are you going to do this? How are you going to get that non-clinical information? People typically think of Fitbits, using an API for maybe home monitoring for blood pressure or blood sugar or something like that. So all of it boils back to that patient engagement within their healthcare, either by accessing their information, by messaging electronically, questions about their health information, or generating their own health information. The third one that's really big is the health information exchange one. It goes back to 90%. 50% of your transitions of care and referrals have to be electronically. It's only 10% now, and physicians are really having a hard time meeting it. So what are we going to do to get you up to 50%? So for more than 40%, so again, this is one that you attest to 3 but have to meet 2. For more than 40% of those transitions or referrals that you receive, you have to incorporate an electronic summary of care record. In the past, you've always been measured on what you sent out. Now you can also be measured on what you sent in. And then the last part of this, you have to do a clinical information reconciliation for more than 80% of the patients. So again, big focus on patient engagement, big focus on coordination of care, huge focus on health information exchange. And with the change of all providers only having to attest to 90 days for program year 2018 when they move to stage 3, it just gives you a little time to look at where you are. Run early, run often. Kind of see how your processes already affect some of these. What can you do differently go ahead and run the numbers. Some of your systems may already have the ability for you to be able to run these numbers now so that you can kind of get a baseline as to where you're starting. I said, I apologize, I don't know what that beeping is. Just some other really cool things that are made possible by having electronic health records and health IT is precision medicine. I actually find precision medicine really kind of fascinating. It's just basically taking information about a patient from lots of different sources and coming up with a care plan, medication plan that is very specific to that particular patient. We see this primarily in cancer and cancer treatments, but it has a lot more wide applications as well. Population health is another thing that you've probably been hearing a lot more about. Population health is a little bit different than public health. Whereas public health kind of looks like at a group of individuals or a group of circumstances affecting a group of individuals, population health kind of looks at it more on a per patient basis as well. It looks like it is more of a disease state. What can be done for a certain set of patients within a certain set of a certain geographic entity with a certain disease state. And it really looks at saying, okay, if you live in an area that has a tendency to have, I don't know, X, Y, and Z, what can we do about that? If you're in a group of people who have a tendency to develop this type of cancer, what can we do about that? So precision medicine is very individual focused, population is very individual focused, but it is still more focused on a group, but it's more proactive. What can we do on the front end versus on the back end as well? It also factors in social determinants of health. You may be beginning to see a lot about this. You know, and I think this has always been around, and I think the doctors have really always known this. I can come to you for a medical condition all day long, and you can tell me what I need to do. You can treat me for whatever that condition is. But if other certain things are not right in my world, I may be the most non-compliant patient. I may want to do right, but, you know, if I don't have basic housing, living, food needs met, then I can't be a very good patient. If I don't have a ride to the pharmacy to get my medication, I can't be a very good patient. I may want to be, but I can't. So I think there's beginning to see the research really support looking at these things when you're looking at the overall health of a patient. So again, not coming in necessarily treating me for X, but if you're going to treat me for X, make sure that I can be a compliant patient with all of that as well. It also kind of goes back into population health in looking at the factors that may affect an overall group's health. You know, we're beginning to see a lot of things come out, a lot of concerns come out about Puerto Rico. A lot of those individuals have been down there for quite a while without power, infrastructure, decent food, decent water, that type of thing. So what kind of diseases, what kind of outcomes or impacts can we begin to expect from that? That's a form of population health. And not only do you think about what could potentially happen, what could you potentially do to prevent that from happening? So identify the problem and go ahead and solve the problem before it becomes kind of unsolvable. So again, the purpose of today's webinar was really in honor of National HIT Week, just to kind of look at a lot of really cool things. It was kind of fun to look back over the program over the last 8 years, almost 8 years, wow, and kind of see how far we've come. We know it's been confusing. We know it's been frustrating. But I think we're at a really good place in terms of what the federal requirements are with modified stage 2 and modified stage 2, even looking ahead to stage 3. I think if we all start now educating ourselves about what those requirements are, educating our patients about what those requirements are, and really educating ourselves, because eventually we're going to be patients about what those requirements are, and not only what the requirements are, but how it really can benefit everyone. And then I think we'll have a pretty smooth transition to stage 3. Lots of good contacts and resources. If you signed on today thinking we were going to go through each of the modified stage 2 measures in details, stay tuned. There's going to be a webinar for that coming up. We are also planning a series of provider workshops focusing on the EHR incentive program, focusing on health IT in general. We're also going to be able to have some representatives of the macro MIPS program. So even though that's more of a Medicare initiative, we know that it does impact our providers, and we also know that having access to that information is very valuable because you're kind of in the throes of getting that implemented. So look for those times and dates. We'll be posting them on our website as well as sending out targeted invitations to the providers in the areas that we're going to be in. Quickly, Florida Health Finder. There's going a webinar on this tomorrow, but Florida Health Finder is a great resource of healthcare information in the state. It's something that apparently has been around for a while. A lot of people didn't even know we had it. You can go in as someone seeking healthcare resources. You can find information about physicians, hospitals, assisted living, skilled nursing, labs, all sorts of really good information. We find it very helpful for maybe patients who, maybe they need to go into an assisted living, but they don't even really know where to start. You can go in and kind of filter it down by the area you're looking at. It has quality reports, cost reports, all sorts of really cool information. We have a webinar on it tomorrow. There's actually a webinar every Friday talking about Florida Health Finder, but here's the website. You can look it up for yourself. Cool stuff going on with our Florida HIE. Join us tomorrow trying to find out the future of where we're going with Health IT, not only with just the EHR incentive program, but all the other services that kind of wrap around it as well. And look for the telehealth report. Telehealth has been a big initiative of the agency for the last year, and some really good things have come out of that too. And I think a much better awareness and understanding of telehealth services within the state and where that whole kind of realm of healthcare needs to go. If you want to sign up for tomorrow's webinar, you can go onto the Florida HIE website, and it'll have a link for you to register. And if this time, I'm going to quit talking. Do we have questions or comments that anyone would like to share? I don't see any questions. I will say, if you could see me in person giving this webinar, I was much more animated. You couldn't see my hands moving as much on the phone. But this is a really cool topic. It's something that I really do believe in. It's taken a while. It's taken a lot longer than I think anybody would have ever thought to kind of get us to even where we are today. Again, if you were back with us in the early days of the program, the debit card, you remember the debit card example, or the cell phone, the smartphone example was always used. When debit cards first came out, it was like, oh, I'm not doing that. I can't trust that. That's not safe. That's not secure. And now I can go to the high school football game and use my debit card. People just don't have cash anymore. The same with your smartphone. I was a big holdout on texting. I'm not really sure why for a long time. And now 95% of my communication, not only on a personal level, but a business level as well, is done through texting. So I'm hoping that just as if those become a mainstay of our everyday life, the use of electronic health records, the expectation of a patient portal, the expectation of an electronic health record kind of becomes that mainstay as well. I know we already see it with our younger population. I have young adult children. It's a rarity. And it almost scares you when they actually call you because everything's done through text. My daughter, who is now 22, she didn't know that you had to sometimes go into a bank. Everything's done through her debit card. She didn't even know there was things such as a check. She'd heard about it, but she didn't know how to write one. So again, times they are changing. So I don't see any hands raised, and I don't see any questions. Thank you for your time today. I hope you have found this informative and encouraging. I do encourage you to sign on for tomorrow. Keep a check on our website for upcoming events and definitely those workshops that may be in your area. Thanks again, everyone, and happy National Health IT Week.